Great. Welcome to House Healthcare. It is Wednesday, April 3rd. And this afternoon, we're picking up S-189, which is an act relating to mental health response service guidelines and social service provider safety. And we have the sponsor of the bill, Senator Lyons, with us. So welcome.
Well, thank you for having me and thanks for taking up the bill. Appreciate it. Senator Ginny Lyons, for the record. The bill started out as protocols for mental health volunteers and providers in a crisis situation, and then has changed during the process. So a little bit about how the reason I introduced the bill. I had several phone calls from people, especially those who are EMTs or volunteers who are responding to a mental health crisis call, and were very concerned that they didn't know what to do, how to de-escalate, how to intervene, anything about their response, or less than they would like to have had. I wouldn't say anything. So and my own predisposition is that it's critically important that our mental health experts, our Department of Mental Health, be involved in training and helping folks learn how to respond in those situations. We've had a lot of them over time. So the original bill was introduced as mental health protocols, and obviously our EMTs, our professional folks, are extremely well trained in medical protocol responses. So when you say the word protocol, it means accountability and responsibility. And so responding, you are literally graded on how you respond, and they're taught airway intervention, or for asthma, or specific types of responses to hypoglycemic patients, or opiate addiction, and so on. And the goal of the bill really was to begin to put some broader emphasis on mental health crisis response for people who may not be the professional folks. At the same time, we also know, if you look at the protocols currently, as I did, and went out online and read through the protocols, there's very little about behavioral intervention or mental health intervention. So it's not robust. At the same time, we all know that our communities have now embedded in our public safety mental health counselors and others who can respond to a crisis. So in taking testimony, I introduced the bill a session ago, and one of the responses from public safety was, "Well, we're already doing it, and this is our job, and we're linking in with our DAs to help respond." For me, it goes beyond that. It goes right to our local communities where we have volunteers going out to respond to emergencies. All of which is to say then, the Department of Mental Health, the Department of Health, Department of Public Safety all got together and brought back a recommendation about changing the language from protocol to guidelines. So providing some information to our first responders about how to respond to a mental health crisis. And so the bill's been amended to do that. And you can, as you take testimony, I think maybe you'll make some improvements, and that would be fine. We worked a bit to get to where we are right now. So it'll be mental health response service guidelines rather than protocols. One of the things I did hear from folks was that as this goes forward, they might be interested in incorporating the guidelines into protocols, just to beef up what is available to people when they are becoming emergency medical responders. So that was the bill as introduced. Then you'll see that there are two other sections to the bill. One is around social workers, and to do an analysis of safety with respect to social workers. So we know in my district, I guess it's my old district now. I think it's Brian's district, not sure. Representative China's district, where we had some terrible events with social workers, and then in Brattleboro, just a horrible event. It was last fall, but yeah, it's all. So the social workers are concerned about their exposure. And so the second part, section 2 of the bill, is to have a group get together and evaluate some of the concerns around social worker safety in their places of employment. Then on the floor, and Katie can help, I don't even have that amendment with me, but on the, we added an amendment around home healthcare folks and their safety. So right now, home health providers go into homes, and home health agencies must serve their clients. They must serve patients. So they have little recourse for not helping patients. But if there's a concern, a safety concern, there's a process that they go through. And apparently it takes a long time for that process to happen. And you can find out from Dale exactly what that process is. And so there was a concern that, well, if someone isn't going to be helping the person at home, what happens to the patient? And is there a way that safety can be provided quicker? The example that we heard about, sort of real example from one of our senators from Rutland, is that his mother was being cared for, and the dog started to get in the way. And so it was a matter of just controlling the dog. So if it's that simple, that solves the problem. But there might be other things that are more complicated. You know, someone who's a little intimidating at the home. So those are the 3 sections of the bill. And it allows for, the last section does allow for some relief and a quicker turnaround for solving the problem. And there's some rulemaking in there, so you can. I haven't looked at the bill in a while, but I think that gives you the general idea of what's there. I am very convinced that we should be focusing more on these mental health issues in emergency situations and allowing for our Department of Mental Health to be fully engaged in developing whatever guidelines or protocols are in place. So that's a big deal.
Great, thank you. Any questions for the senator?
Just, Senator, it looks like it's for emergency situations only.
Yeah.
Yes, okay.
Yeah, it is for, crisis response,
type
yeah.
intervention. Okay.
If you can think of other needs.
Yeah, and it looks like section 3 gives them the right to deny service if there's a problem.
If there's a problem, right? that
Okay.
Can die. And
Yeah.
that's another process. Part of that'll have to be worked out in the department
Yeah, right,
through rulemaking.
right. Thank you.
Daisy?
Did you take testimony, and could you just kind of give a broad picture of what some of the stakeholders who would have access to the training or guidelines? I guess my concern is, do you hear any expressions of concern about being able to meet the guidelines or complete trainings or anything like that?
Did not. And what we did hear from Kristen Chandler, a coordinator of Team 2, is that we need more education. So she has a program where she educates folks for, I'll tell you the number of hours, for a specific period of time, and then they have to come back for an 8-hour session. And what happens is people are working and people don't have the time to commit to come back for that second session. So her comment was, we need more training, we need more education, we have to get information out more. I did not hear from anyone who said they wouldn't want the training. Am I answering your question?
Yeah.
Okay. Yes, so there are different levels of response. And this is probably not the lowest, but a lower level of just giving people some information that when they're confronted by someone with a mental health crisis, first they'll recognize it. They can recognize it maybe as depression, or they can recognize it as some manic episode, so they'll be able, or psychotic episode, to be able to sort of decide what they should or should not do.
I'm sure you're familiar with mental health first aid.
I am.
How would this compare to that?
No, this is different. I mean, so these are probably more formal guidelines for people, just having it in their toolbox for not treating someone, but actually recognizing the need for some specific response.
Brian, and then you can go.
I have two questions. One is, the harder one, I think, which is, for section 3.
Yeah,
It makes sense that we would set a limit with someone if they are causing harm. So that they can't continue to cause harm to like workers, but then what?
exactly.
Then what? Like, what do we do about that? Because they're gonna go out and hurt other people if they're not getting treatment.
Well, if it's, there are different scenarios that you might describe. It could be the Alzheimer's patient who has become really difficult. It could be the husband of a patient who is difficult. So it may be an opportunity to have some rules in place, that the intervention might be to have rules in place that would say, okay, you can't be here when this person is giving care. So it's not categorical. It's not, it's not saying they won't have care at all. It's trying to mitigate the problem first. And then I can't tell you what happens next. What would be the worst case scenario is that the person would not have a caregiver.
Yeah, well, I think so I want one other question too, but I can wait for others. But just to follow up on this, and we can take more testimony on
We
it,
will,
but like,
Yeah,
but I think, the guidelines part in section 1 are gonna inform some of that, but I think the question is, like, I'm not saying that we should be sending home health providers into dangerous situations, but like, if there's a person, I'll give 2 cases. If there's a person who has a neurocognitive decline issue and they're becoming violent and the nurses can't safely go there, do we just leave them to their own devices, or is there going to be some other thing? We don't have to answer that today, but that's kind of the question. Like, is it going to be then, crisis response showing up at the house? Is it going to be the police or fire department? Are they just going to die because no one's going there? That's the physical stuff. Then there's, with the mental health stuff, like if it's like a mental health issue where I guess if a home health providers, and I think the home health providers can probably answer this when
Yeah,
it's
I
their
was gonna
turn.
say, we'll take.
But maybe like
Yes.
we can wait for that. But I think if the home health provider's going, I'm assuming there's a physical medical condition. They're not going just to check on someone who has a mental health condition only. But like,
this section is not related to the first section, so it's a
Right.
separate section.
exactly, they're separate. So like, we can hash it out later, but I'm just curious how, I guess the ultimate question is when a person's behavior is causing so much harm that it's unsafe for workers to go to their home, how do we try to continue to offer support, or how do we make sure we don't just abandon the person? I think that's the question.
So can I, let me comment on that. I mean, there is a section in that section that allows for rulemaking, and that may allow for someone to be accompanied. Because I'm hitting a little.
That makes sense. So there might be that everyone may hash it out.
Yeah, so you could have public safety, or you could have someone else, when you have a DCF worker, for example, going to a home, sometimes they've had concerns about having public safety along. So there could be something worked out.
Yeah, well, I will say, like, as a crisis worker, there's been times where it isn't even a safety issue about the person. Like fittingly, there was a situation where there was a blizzard and I had to drive into the mountains in a snowstorm, and the state troopers met me and they rode up the road with me, because if I got stuck, they were with me. And that was great, and then they waited outside the house, but they were there to make sure I got up and down the mountain safely. So I think like there's ways that we let people figure it out.
I think there'd probably be a lot of people in the community who would want to see that happen.
Yeah.
Nobody wants to abandon.
No, I don't think so either. Yeah, that's why
I
I
agree
asked.
with you. Yeah.
And then the other question was just related to the training thing you said, because I've done the team 2 trainings and like they didn't seem adequate. So I do think there's room for us to look at training models and like how do we, I'm not saying there's not value to that training, but like I think where I might agree with that with team 2 trainers is that more something else or some additional stuff needs to be done. So I do think there's room for us to talk about that more. But so it really wasn't a question as much of like validation or something like that. I think like of what you said, and I think like we need to really look more at consistent training across all first responders and public safety people.
Right. Yeah. So one of my concerns is that we're losing people rapidly. And with the pandemic, they've been on so much stress that they can't continue to do the work that they're doing. So anything that you can do to improve some outcomes would be great. And that goes for the whole bill. I mean, the social workers, the home health people, it just, they're not sufficiently rewarded for the work that they do.
And we're abused. I mean, I think that's what this is about. We're being increasingly abused by patients, you know? So it's like, it's getting hard.
So we're gonna do two more questions, I think there are, and then we need to move on. Leslie, and, the 3 more questions.
Very quick, how did the vote come out of committee?
5-0.
Thank you.
Leslie?
Yeah, I'm just not sure I'm understanding, so help me with clarification in section 2. It's in section 2, part 2, describes studies, may review both studies related to social work provider safety. I wasn't sure what that meant. That's line.
Oh, related to social work providers.
I didn't know what studies you were talking about in there. On
So I think
It's under section 2.
page 3, line 2.
So we can also have Katie walk through
Okay.
that.
Yeah.
I think, yeah.
Yeah, you go through section 2, you'll probably, it'll catch up.
One last question.
And I'm just new to some of this work. So what is currently, what kind of safety precautions are in place now for our home health agencies if someone is?
Good question
Yeah.
for Jamaz.
We'll have.
Yes, I think she's the expert. Yeah.
I'm so safe.
Anything else?
Thank you.
Thank you, Senator, very much.
You know what, for me, this is a little tiny bill, but
Oh,
it's
yeah.
gonna make, I hope, it could make a big difference in people's lives.
Definitely would.
Definitely.
On both sides of the equation.
Yeah, exactly.
Yeah.
We were at a hospital today and they were speaking about.
I just heard about that.
It was great.
Was that the chainsaw?
No, that was at MVRH
Oh,
in St.
oh,
James,
yeah.
but nobody went to see a
Oh, you went,
CVEMC.
oh, you did, oh, good.
They were speaking about the need for safety.
But yeah, the chainsaw was about
I
as
know,
scary.
that's another one.
Yeah, that's not.
We did that last year.
I didn't hear
Thank
that.
you.
Thank you, Jim.
Thank you.
Thank you very much, Senator.
Take care.
Yeah.
Good luck.
There's pound cake.
Good afternoon. Thank you. Katie McGlynn, Office of Legislative Counsel. Let me share my screen. I know you have a lot of witnesses, so I'll try to move quickly. So as Senator Lyons said, there are 3 distinct sections in this particular bill. The first section is the mental health response guidelines. It directs the department, meaning DMH, to develop guidelines for the use by municipalities, including use by EMTs and public safety personnel, such as law enforcement officers and firefighters who are employed, volunteer under contract with the municipality. The guidelines shall recommend best practices for de-escalation and for mental health response services, including crisis services. The department is to make the guidelines available to municipalities and publish them on the department's website. And then in subsection B, we have a list of who the department will consult with in developing the guidelines. The Department of Health, Dale, DPS, Vermont Care Partners, Vermont Psychiatric Survivors, Vermont Chapter of NAMI, Vermont Criminal Justice Council, Vermont League of Cities and Towns, and any other entity that the department deems appropriate. So that is section 1. Section 2, transitioning to social service provider safety. So this was added, I think, right before it went to the floor, right before second reading. And this is a request that on or before November 15th, the Agency of Human Services in collaboration with the Vermont chapter of the National Association of Social Workers, is to convene one or more meetings related to social service provider safety with community-based social service organizations. And then it says the following community-based social service organizations and professions may be included in this meeting or meetings. Vermont Network Against Domestic and Sexual Violence, Vermont Coalition to End Homelessness, mental health and healthcare providers, community action programs, restorative justice service providers, and disability service providers and advocates. And in advance of one or more meetings described in subsection A, participating community-based social service organizations and professions may review both studies, meaning studies generally about the field of safe social worker safety. So both studies related to social service provider safety and individual social service provider safety experiences.
That's my question now.
That's right.
Subsection B, by January 31st of this coming year, AHS, in collaboration with the Vermont chapter of the National Association of Social Workers, is to present findings and recommendations to the various policy committees, including a list of community-based social service organizations that participated in the meeting or meetings and the number of meetings convened. Section 3 is the language that you have been just talking about with regard to home health agency employees. So this language was added, I think, prior to third reading, or during third reading, I think. If an individual was previously discharged from service by a home health agency to protect the safety of staff in accordance with the rules adopted by Dale pursuant to another section of that chapter, the behavior or conditions causing the discharge cannot be mitigated or eliminated. A home health agency may either deny a subsequent admission or decline to send a home health agency employee to make a visit if the agency has reason to believe that the individual who exhibited the behavior that resulted in the discharge is present at home. So just to be clear, this is cross-referencing rules that already exist.
And so there was a previous situation that caused the person to be discharged.
Yeah, the person, there's a
Previously
the
discharged.
lead in language, if the individual is previously discharged from service.
Okay, right.
Mhm.
And we'll get some more clarification on that from when Jill testifies.
That's my, yeah. So is there already rules? Why do we need it?
There are rules in this chapter where this is being added. There are rules. There's language that directs Dale to adopt rules, but it's not specific saying these are the circumstances in which you should deny a person service. I think there are Dale has adopted some language in the rules about when service can be provided and can't. It's not done with statutory guidance, though. It was
This will be strengthen it.
it was sort of a delegation of authority that the General Assembly said you could adopt rules. And this provides some more statutory parameters around when a denial of service can happen.
And then did you want to ask your other question?
Yeah, if I may, I'm still confused about that studies piece because I'm not sure what that's referring to. And
Yeah,
maybe I'm just having a mental breakdown.
okay. So this is saying that people who are attending the meeting can review both studies and anecdotes of provider safety.
Oh, both
Yeah,
both
I
studies.
hear why you're confused. It sounds like there are
There's a
two
syntax
studies.
kind of-
Yeah.
Okay, got it. Thank you.
Katie, on 3, back to 3.
Mhm.
This deals with a previous circumstance when there was violence. And so now, because of that previous thing, if we think the individual who's violent is there, we can deny service. Are there things in statute or rules that cover you go to the home and there is violence and now you back out and deny service?
There might be something in the rule. Honestly, there's only, I think, one person who testified downstairs, so I have not sat through much
Okay.
testimony.
We're gonna hear testimony on this, so
All
can we
right.
save that
Yeah,
question?
I mean, that,
It's a key element.
yeah, it's an important part of this, you know.
Absolutely. Any other questions for Katie on the language? Stand up. Welcome.
Thank you. I think Nicole's gonna share slides behind me, but I have my notes in front of me. My glasses are for distance, so at age. Okay. I'm ready.
All you.
All right, Samantha Sweet, Director of Mental Health Services at the Department of Mental Health. And I am here to talk about, just gonna make sure, okay. Coordinating mental health response guidelines. So as you have all heard about 988, alternative CED and enhanced mobile crisis, you know that over the last 2 years, we have been leading that charge of expanding statewide mental health crisis system of care. So our aim, DMH's aim, is to coordinate the efforts between all of 988, mobile crisis, alternative CED, and first responders through standardized training crafted by mental health experts to equip all responders with knowledge and skills necessary to address mental health emergencies skillfully. So this is capturing kind of what the landscape is right now for both 988 and mobile crisis. And this is not an exhaustive list, but rather just highlighting some of the trainings that both 988 and mobile crisis teams currently do. And what we have done is tailored the trainings to match what the service is. So you'll see for 988 services, we have trainings that are focused on crisis conversations and how to respond to a crisis via chat or text. We have crisis counseling for 988 services. And then for our enhanced mobile crisis teams, you'll see that we provide training or required training around substance use, mental health services, connecting to 988, trauma-informed care, harm reduction, cultural competency. So it's very tailored to what the service is. And again, this isn't an exhaustive list, so some of them overlap both into 988 and mobile crisis. This next slide. So as I had mentioned, we looked at the current trainings across all responses, 988, enhanced mobile crisis, and what's required and what's recommended to show you a sample list of what DMH felt was important for first responders. I want to note that this is just a sample list, and DMH would want to facilitate some stakeholder meetings to gather feedback from those that are doing the first responding, whether it's EMS, fire, law enforcement, to see from their perspective what trainings they currently have and where we can build off from that. So, so you'll see this list, again, not exhaustive. This is just a sample list of understanding mental health and substance use and how they interface. And what we know and what we see a lot is people that are not in this world don't know the services that are out there. And so really doing a 101, what is out there? What's a DA? What do they provide? What services? Same with substance use. So we would also recommend doing an overview of mental health crisis system of care. And we have for many years had a crisis services. Recently, in the last 2 years, like I just spoke about, we are now getting a crisis system of care, which is including 988, enhanced mobile crisis, and alternative CED. So talking through those and how they overlap and intertwine and how one feeds into the other. So we now have a whole system of care in the crisis world. trauma-informed care, as we probably all know, is super important. That's about safety, about choice, about collaboration, trustworthiness, and empowerment of the client. So it's ensuring the physical and emotional safety of those that are served in a very trauma-informed care type of way. And then another training that, again, this is a sample, but this is something that we see as important, is creating safe scenes training, which is a training that helps first responders assist individuals with mental illness and substance use disorders who are in crisis using safe and positive approaches. It's making safe connections, de-escalating situations, and coming up with referrals. So what are the benefits of standardized guidelines? As you heard from Senator Lyons, this is not an exhaustive list. As you can imagine, that there's many reasons why standardized guidelines should be created. But we do see this as enhancing coordination across services, leading to more effective responses to our communities. We also see this as improved outcomes in the crisis responses, as we will be integrating, providing knowledge, and increased trauma-informed approaches. So that brings us to recommendations. And DMH recognizes the unique role of 988, enhanced mobile crisis, and first responders play in our community. And DMH is advocating for a cohesive yet role-specific training approach. And legislative language should strive towards standardization, with also allowing that flexibility to train based on the various roles. And that is all I have for this overview.
Dr. Brian Daisy.
Can you just elaborate a little bit more on trauma-informed care? I don't get it yet.
Yeah, so it is a type of approach that professionals, and there's a lot of trainings for the non-professionals as well, to approach someone in a very caring way. So you're not creating more harm. You're de-escalating the situation. You're making the environment safe. You are making sure their emotional, their physical safety is first and foremost. It's how you talk to someone. It's not using demeaning language. It's really going about it in a very caring and nurturing way, so you're not creating more harm to the situation.
So you're not
Does that-
providing more trauma to that person.
Right, right.
Get it now.
You're not going in and escalating the situation further. You're using, softer tone and doing things to de-escalate.
Right?
I want to say more about trauma-informed care.
Yeah.
That I think part of it too is like interpreting people's behavior through a lens of like trying to be empathetic to the trauma they may have experienced, so the way they react to you, not taking it personally, but being like, what I just said doesn't warrant this response necessarily under normal social conditions. Like, instead of being like, oh, they said that about me and puffing up, you're like, this isn't about me. Something happened to them. And so it goes back to the being caring. I could say more because I do a lot. I've had a lot of this training, and that's where my question comes in are you like responsible for like these statewide like online trainings that we do as providers, like Relias, and I forgot what it's called. Like there's like these online at the Howard Center now, we have to do like, in addition to the agency trainings, there's online trainings that we have to do as part of crisis response that we've been doing and like to get into compliance. And so are you part of that? Like the people who plan all that? Is that what?
As far as I know, I think that is a agency specific requirement for training. And so DMH, we highlight things that are important, like we say trauma-informed care is important to take, making sure staff safety is important, but we don't say this training you have to take. That's up to each individual agency.
So who is the one who is like mandating in a good way? I say it's mandating that all the mobile crisis responses in the state take these 6 or whatever this core.
Yes, the new enhanced mobile crisis.
Yeah, who's responsible
Yeah.
for that?
So that is part of our funding coming from SAMHSA of like, this is what the framework is, and here are the trainings
SAMHSA
that.
is the one. Here we go. This is what it is.
Yeah.
SAMHSA is the one requiring it. It's not a bad thing. It's just that
No.
there's, because I have not seen that in like 20-something years where every crisis response is having to do something the same
Yes.
versus what you were just saying, which is there's agency specific.
Yeah, so it's really a statewide approach.
Mhm.
So everybody has the same training versus
Yes,
each
exactly.
individual county or agency deciding on their own trainings that are important.
Because it gives like the people more consistent experience
Yeah.
wherever they are in Vermont. So it's a good thing. I just wanted to know if you like, what you were just talking about sounded like what these trainings were.
Yeah. And with enhanced mobile crisis, it is a statewide approach. So hopefully people are responding even outside. We're breaking down the walls of just responding to your county. And so you could respond to the county next door because it is now a statewide approach. So we really needed to do it a systematic way.
Daisy, then Elizabeth,
Um,
Daisy, then Leslie, then Art. Sorry.
I have kind of a foundational
Oh,
question about Bill and given that the title is about social service provider safety. And I think there's something important for us to know as we begin to kind of dive into this bill. And it's related to how, staying patient focused. I realize it's about social service provider safety. And as someone that spent a large portion of my career representing mental health providers and substance use treatment providers, I deeply appreciate the intent behind this, but I also want to hear from you a bit of, with your recommendations, can you give us some perspective on the incidence of violence in the community of folks with mental health challenges or mental illness?
Yeah. I can speak in general terms. I don't have any numbers in front of me or anything like that. And probably more than anybody else of like how people with a mental illness are more often the victims than the perpetrator of abuse and violence. And so I just want to make sure as we're talking about this, we're talking about it in a very respectful way, because oftentimes those that are the victims are individuals that have a mental illness. And so, but that's not to say that it doesn't happen in our communities, and we know that it is happening. And so how do we protect the person that we're serving and protecting the people that are doing the servicing? So that is why we're here. We don't know what types of trainings are out there for first responders. And I think that some people there may be some counties that have some training and EMS does go through some training. Some other counties may have nothing and they're responding. So I think that this is an attempt to at least lay some framework out of like, here are the services in your county that you may not even know about, or here is what mental illness is and substance use, and here are the symptoms. And you bring up mental health first aid, and I think that's a great overview of like anxiety, schizophrenia, and disorders like that. I think that's also bringing to the community of how do you de-escalate situations? How do you make sure a scene is safe for everybody involved? So
That's helpful.
yeah, thanks.
Leslie?
I just went forward in your slides and you included a slide about EMS protocol development. And I've just been sort of learning about the difference between protocols and guidelines. So that's interesting. But I'm wondering what you're trying to communicate with this slide. I mean, this is from you, right? Yeah.
Which slide are you talking about?
The EMS services slide, it's slide 7 of 9.
Yeah.
Yeah, okay, sorry. So this is Nicole DeSazio, I'm the Director of Policy for the Department of Mental Health. I actually included that not in the main content, but in the appendix.
That's right.
It comes from the Vermont Department of Health. They
Right.
wanted you, in the community is interested to know what does the EMS process look like for developing and revisiting the protocols. So if you wanted to do that, that's in there for your benefit, but we weren't planning to provide testimony on it today.
I was just wondering how it fit together because does this bill supersede that? Does it intersect? How does it fit together?
So I think, as Senator Lyons said, the protocols are essentially what is considered the standard practice, like what is expected in the field. So you could actually be subject to criminal or civil liabilities if you don't meet those standards of care. This would not raise to that extent. We're talking about something like guidelines to help people understand or improve the care that they're being able to provide when they're responding to crisis. We're not going to develop protocols. That being said, we would love if this work informed the redevelopment of protocols, so that way that process can also work here, but we're just very careful about letting that kind of play out a little bit more organically and naturally. So we're gonna do this, we're planning to do this work, we've already started it. And then hopefully that will feed into the EMS process, and it's there if you wanna, as I said, if you wanna kind of see what that process would look like.
But in section 1, you talk about developing guidelines for use of emergency medical technicians. So wouldn't the DMH guidelines?
Guidelines, not protocols.
Excuse me, DMH
Yeah, the
protocols.
word really is.
So the DMH protocols apply in that setting?
We're not developing protocols, we're developing guidelines.
No, but I'm wondering about the ones that already exist. I'm trying to understand, and maybe I'm missing the point of, that the the VDH protocols exist for EMT.
Yes.
Right, okay. But in section 1, you talk about guidelines for emergency medical technicians. I just wondered how those square, and maybe they don't. Maybe there's no relationship.
If there's already protocols for EMS, why would we do guidelines?
Yeah,
Well,
thank you.
and I think that's what Senator Lyons was saying was that there's not sufficient training and there's not sufficient
Standardization.
in the current protocols that the EMTs have.
So that's what she's referring to, that.
Yes, but the EMTs they're licensed by the Vermont Department of Health, so DMH can't actually go in, and we don't have the authority to actually force them to follow our protocols. Like, they're licensed by the Vermont Department of Health, that they set the standard of care for the field. We're gonna create guidelines to help inform that, and that should then move into that protocol process. But the guidelines that DMH creates will not proceed in the kind of order of operations, the EMT's protocols. That is what they're licensed for. It is a little bit confusing, I will be honest. Does that help?
Again, yes and no, but enough for now.
The VDH might be able to explain that a little bit better if you have a little Moran come in. Art?
Just a quick question.
Yeah.
Do you, Samantha, do you support section 1 of the bill? Have you looked at
Does
it?
DMH support?
Pardon me?
Does DMH support?
Okay, okay.
That was my question too, so thank you.
Oh, I
So yes,
hear it.
DMH supports the language as is.
Yes.
Okay, thank you. Melanie?
And I'm just making sure I'm understanding this correctly. This set of guidelines would be uniform across the state for all municipalities. It's not, there wouldn't be a separate, like they couldn't change it by municipalities. This is the one that goes.
Yeah.
Thank you. Easy.
I notice on, in section 1, the development of guidelines includes several entities, and it doesn't include state standing committees. Was that ever discussed?
Oh, that's a great point. That was not discussed, and maybe that was an oversight. We would definitely want to include conversations with state standing committees.
Okay.
And does DMH have any comments in section 2? The social work section?
No, not at this time.
Any other questions for Samantha? Great, thank you.
Thank you.
Great. Christopher, are you with us?
I am here, yes.
Hi, welcome. Thanks for
Thank you.
joining us online. And if you can introduce yourself and then start your testimony, that would be great.
Absolutely. For the record, my name is Christopher Burkell. I'm the Deputy Director of Vermont Criminal Justice Council. And understand that I've been asked to just testify on this bill specifically. I think where my testimony might be relevant is regarding just section 1 of this new proposed language.
Yes.
And I've heard some very interesting conversation just in your testimony today. And I'd like to point out one thing that I heard from the Vermont Department of Health, which I think is a great recommendation, is the fact that one of their recommendations is that there should be created standards while being flexible. And why is that important? And that's because of all of the groups that you have that interact, whether it's EMS, whether it's law enforcement, whether it's firefighters that are responding to these types of calls, each has a different level of responsibility. So law enforcement has their own policies and their procedures to follow, and they also have the law behind them to take action when needed. Firefighters have certifications, so do EMS, and they have protocols that they have to follow. So I think a guideline that would kind of connect all of those folks together is certainly something that would be welcomed by the Vermont Criminal Justice Council for law enforcement to be a part of, and also to have an understanding of all of the entities that might have a responsibility in responding to a mental health crisis or that type of a call, and exactly what is expected of each of those entities, right? So it's important for, like in our profession here at the Vermont Criminal Justice Council, there are all kinds of different types of trainings that take place. So we have de-escalation training. We provide Team 2 training here for law enforcement and mental health crisis workers. We have scenario-based training. De-escalation is taught in communication skills and in interviewing, even in patrol procedures when they're stopping vehicles, they're interacting with people. That can turn right into a mental health episode, or it can be drug related at the same time. Having those communication skills and being able to de-escalate are key to successful responses. But what's even more important is for a law enforcement professional to go out there and know what their community has for resources and responses to help them get through this process, and also to not interject themselves where they might create something that's more of a problem because they weren't the right tool to be used in the situation at the time. So I think hearing the conversation about overall guidelines while being flexible is a great way for all of the entities that you have outlined in section 1 to be able to have a common understanding of their roles and responsibilities and where they interact with each other and where they work really well together. So just to give you an example, for law enforcement has a statewide mandatory use of force policy. In that use of force policy, there is an appendix, I believe it's Appendix D, and it is specific to use of force policy that is specific to persons known or to be perceived to be experiencing mental health impairment. And in that appendix, it covers things like, what are the signs, whether they're real or perceived, of mental health impairment? What are the possible reactions to use of force? What guiding principles should you follow in responding to those calls? Legal considerations. What accommodations that you can make for those folks? What actions do you take prior to even responding to those types of calls? And it's really self-regulated to law enforcement to, when you do respond to these calls, slow down, which is not what the normal form of response from law enforcement used to be. It was to go in and fix a problem. Everything is to slow down and start to be able to listen, and most importantly, self-regulate. Because if the officers responding can't self-regulate themselves because of the enhanced dynamics of whatever that call is that they're going to, that doesn't help. So all of these things are just within a use of force policy, in addition to other policies that they have. I do think that law enforcement does a really good job of knowing what their communities, and they do vary widely throughout the state, have for services. They also know what not to utilize. So we all recognize the challenges that emergency rooms are facing with these folks being sent to, sometimes unnecessarily, to an emergency room and taking up valued services there. So as an overall comment, I would say that the Vermont Criminal Justice Council is certainly interested and involved in being a partner in working with the Department of Mental Health and being a collaborator in whatever those guidelines look like, and to be a partner in the fact that we could host the training here, we could be a part of the training here and offer it to a wide variety of folks that would benefit from that type of training.
Great. Thank you for that overview. That's helpful. Do you have comments specific to the language? Are you comfortable with section 1?
Hearing some of the conversation, when I initially looked at it, I was wondering why specific, like emergency medical technicians, which is a very specific level of certification. And then it included public safety personnel, which was fairly general, and firefighters. Why it didn't include just all EMS personnel that might respond to these types of calls. So I'm not the legal expert in the definitions that should be in there, but that just popped out at me as an EMT. To me, as a former law enforcement person, is a very specific level of skill as opposed to someone who provides an EMS response.
Okay, so we'll work with Katie a bit to make sure the definitions aren't making it too narrow for us. Okay, that's helpful. Any questions, Melanie?
So all those individuals that could respond that were just listed, when we look down at the group that will be making the guidelines, who are they represented by? Is that by public safety, the department number 3? Is that
I'm sorry, was that question to me?
I think so. I just don't know. When we look at who that are going to be getting this training, I'm just curious as to when I look down the list of the people that are going to be charged with making these guidelines, I'm just wondering who represents them. Is that the Department of Public Safety, or is that the Criminal Justice Council? I mean,
They're all actual different entities. So the Department of Public Safety would be, assuming from the Commissioner of the Department of Public Safety, there are very specific different entities. The Vermont Criminal Justice Council could certainly entertain and assist in the development of what that collaboration looked like as far as training goes. You have all of the agencies that I see there that would certainly be a part of being able to craft what a response guideline would look like.
Thank you.
Any other questions for Christopher? Great, thank you so much. We appreciate your testimony.
You're welcome. Thank you.
Listen.
So Nicole, I just reviewed that EMT thing that you said, and there's nothing about mental health guidelines or a training or anything. So totally 2 separate ideas. Okay.
Good. Okay, we got that figured out. Okay, so that's what we have for testimony today. We have a lot of testimony scheduled for tomorrow afternoon on this. So tomorrow we have 2 designated agencies to continue with our process there, the floor, and then S-189 we come back to with, like I said, quite a few witnesses. And, this is kind of now where we shift from lots of floor time. We're going to be back in committee in the afternoon. We have 3 Senate bills, and we'll continue some of the other work we have. So we will see you back here tomorrow at 9.